Welcome to This Explainer. Today, we're stepping right inside the human heart during an absolute crisis. We're going to explore one of the most high-stakes, adrenaline-pumping scenarios in all of medicine. It's a literal race against time, where the heart's natural rhythm completely derails, and modern medicine has to step in to halt a deadly cycle before it's too late. Just imagine the sheer chaos and terror of this scenario for a second. The heart, which normally beats with this perfect, quiet precision, suddenly begins misfiring at hundreds of beats per minute. Blood pressure drops, the patient collapses, and just when the medical team shocks the heart back into a normal rhythm, the cycle instantly starts all over again. It's terrifying. So, what exactly happens when the heart's electrical system creates this perfect, relentless storm? Okay, let's dive into this and anchor it to the exact clinical definition. An electrical storm, or a VT storm, isn't just a single dangerous heartbeat. It's defined specifically as the occurrence of 3 or more episodes of ventricular tachycardia, where the heart beats dangerously fast, or ventricular fibrillation, where it just uselessly quivers. Crucially, these must happen within a single 24-hour period and require medical intervention to terminate. The key here is that 24-hour threshold. This isn't just a one-off event. It's a barrage of life-threatening arrhythmias.
Now you might be wondering, how does this differ from other heart issues? We really need to distinguish between two terrifying yet distinct conditions here. On one side, you have the electrical storm, which we just defined, 3 or more discrete, rapid, life-threatening attacks that require a shock or medication to stop. On the other side, we have what's called incessant VT. In this case, the patient might actually be hemodynamically stable, meaning that blood pressure is kind of holding up. But the abnormal rhythm just continues to recur shortly after any conversion to a normal rhythm. It's this relentless, inescapable, continuous loop, sometimes even caused by the very antiarrhythmic drugs meant to fix the heart in the first place.
Look, whether it's an electrical storm or incessant VT, we are looking at a literal race against time. If the clinical team can't break this deadly cycle, the patient faces rapid cardiac decompensation, which basically means the heart completely fails to pump. The clinical stakes absolutely could not be higher, and the imminent threat of death hangs over every passing second that the heart muscle remains unstable.
To put that into perspective and ground just how urgent this is, think about anyone you might know with a history of severe heart issues. Electrical storms occur in up to 20% of patients who already have a history of known ventricular tachycardia or who have previously been resuscitated from sudden cardiac death. That's 1 in 5 of these high-risk patients experiencing this terrifying cluster of arrhythmias. It's a huge number. And we really must remember the human toll behind all these clinical terms. Behind the chaotic lines on the EKG monitors are terrified patients. They're experiencing rapid physical collapse. If they have an implanted defibrillator, they're enduring frequent, incredibly painful shocks to their chest. It's no wonder that repeated shocks, even when they're life-saving and entirely appropriate, frequently induce profound post-traumatic stress disorder. Without immediate, effective treatment, there's a very, very high risk of death. So, how do doctors actually fight back? Well, it starts with triage and some seriously intense medical detective work. The medical team has to instantly figure out what is causing the heart to misfire. They're looking for precipitating factors, like a decline in cardiac function, the emergence of ischemia, which is basically tissues starving for oxygen, or serious electrolyte abnormalities. You simply cannot stop the storm permanently if you don't find the spark that's igniting it. Now, what's really interesting about this slide is you can see that exact spark in action. Notice the red arrows on this tracing? Those indicate premature ventricular contractions, or PVCs. Following a heart attack, surviving heart cells can become highly irritable. Just a single PVC triggers this chaotic wave of ventricular fibrillation. And immediately below the rhythm strip, you see the blood pressure tracing just completely plummet. This is the exact moment of prompt hemodynamic collapse, literally caught on a monitor.
It's honestly like a giant puzzle. Identifying the specific electrophysiologic substrate dictates the immediate counterattack. It's like figuring out exactly which wire in a house is short-circuiting. If the trigger is myocardial ischemia, the frontline therapy is emergent revascularization and beta blockade. If it's long QT syndrome, intravenous magnesium is the immediate go-to along with pacing and potassium. For Brugada syndrome, medications like quinidine or isoproterenol are deployed. And if the storm is caused by an inflammatory cardiomyopathy like cardiac sarcoidosis, the team pivots right to steroid pulses and anti-inflammatory therapies. The treatment has to perfectly match the substrate.
But hey, while that diagnostic detective work is happening in the background, the patient still needs immediate stabilization, right?
This is where the medical team mimics a calm, highly coordinated code blue response and brings out the frontline pharmacological arsenal to suppress those life-threatening rhythms.
Let's move to and see how this builds into a universal, three-step global storm strategy. Step 1, relieve the triggers. That means actively correcting any electrolyte imbalances or restoring blood flow to ischemic heart tissue. Step 2, aggressively reduce the sympathetic drive, essentially shutting down the body's panic response using beta blockers and deep sedation. And step 3, if medications fail, escalate immediately to advanced mechanical support and procedures like catheter ablation. Looking a bit closer at step 2, these are the key suppressive medications used to stabilize the myocardium. Beta blockers are absolutely critical to blunt that sympathetic tone. Then there's amiodarone, and the data shows that amiodarone combined with beta blockers acts as this powerful 1-2 punch, proving way more effective than either medication used alone. Lidocaine can also be deployed, and, as we noted earlier, intravenous magnesium sulfate is specifically used to suppress the unique rhythm known as torsades de pointes in long QT patients.
We also mentioned sedation, and we really need to completely reframe how we think about it here. So the crucial point is that putting a patient to sleep during an electrical storm isn't just about comfort. Actually, scratch that. It's way more than that. Yes, sedation allays the incredible anxiety and provides pain relief from those violent defibrillator shocks. But more importantly, it is sedation for survival. Deep sedation or general anesthesia acts as a profound medical intervention to physically cut off the adrenaline and sympathetic outflow that is literally fueling the cardiac storm.
But what happens when the frontline medications and deep sedation just aren't enough? When those arrhythmias break right through the pharmacological shield, the medical team has to escalate care to some pretty drastic, heroic measures just to keep the patient alive.
And that brings us to advanced support systems. To further block the nervous system from aggravating the heart, doctors might perform a percutaneous stellate ganglion block. Think of it kind of like cutting the specific nerve wire in the neck that sends panic signals directly to the heart. They might also use upper thoracic epidural anesthesia. And if the heart is failing completely under all this stress, they'll implement mechanical ventricular support. This includes intra-aortic balloon pumps or even ECMO, extracorporeal membrane oxygenation, which is a real game changer because it literally takes over the pumping and oxygenating functions for the failing heart. At the exact same time, if the patient has an internal defibrillator, or ICD, the team needs to urgently defuse the device to protect the patient's mental health. Proper programming is so critical here. Instead of just delivering traumatic shocks, the ICD can be reprogrammed to use anti-tachycardia pacing, or ATP. By delivering a sequence of rapid, totally painless pacing beats, the device can actually overdrive and terminate more than 70% of VT episodes without ever having to shock the patient. Finally, for a lot of these patients, the definitive cure honestly sounds a bit like science fiction: catheter ablation. And this brilliantly illustrates the pinnacle of modern electrophysiology. Doctors insert a catheter right into the heart, use an advanced electroanatomic mapping system to find the exact microscopic circuits or scar tissue causing the misfires, and then they deliver radio frequency energy to burn and destroy that specific abnormal tissue. It targets the very substrate of the storm, whether that's a PVC triggering site or a scarred pathway from an old heart attack. By systematically combining all of this, diagnostic detective work, aggressive pharmacology, and mind-bending procedures like catheter ablation, modern medicine can literally halt the perfect cardiac storm, which really leaves us marveling at this ultimate question: how does the ability to map and burn microscopic circuits inside a beating heart turn a guaranteed death sentence into a survivable event? It's incredible to think about what human ingenuity can do when it comes to rewiring the very spark of life.